Well, good afternoon, everybody. Welcome back to this, the first full panel session of the Quantitative Imaging Workshop. This one is focused on issues of quality assurance, metrology, and some of the technical requirements to make sure that we get good data to get good reproducible quantitative results. This is divided into two sections. The first is going to be focused more on some of the clinical challenges, and the second on some of the more basic science technical challenges. And for the first session, Bob Smith is going to be the moderator, and I will monitor the questions and chat room. So if any of you have questions to enter, please do that as we go along. And this session is co-sponsored by the American Cancer Society National Lung Cancer Roundtable, which has several task groups, one of which is an advanced imaging task group. It's co-chaired by Mike Mitnick-Gray and myself. And so many of the speakers today are involved in that task group. We've been putting together a report, which is close to finalized and will be published soon, we hope. And so Bob is representing the American Cancer Society because of this partnership here. And Bob, I'll let you take over and moderate this first hour.
Thank you, Dan. This first hour is focused on the clinical perspective. What are the challenges and hurdles hindering the implementation of advanced image analysis tools for CT screening? Our topic overview is going to be provided by Dr. Gregory Sorensen. I'll introduce him now. Dr. Sorensen is a board-certified neuroradiologist and chief executive officer at Deep Health Incorporated, focused on using machine learning to bring the best doctor in the world to every patient. He also serves as executive chairman at IMRIS. He is on the supervisory board of Siemens Healthineers AG and on the boards of other private and public companies. And prior to Siemens, he was a full professor at the Harvard Medical School with additional appointments at the Massachusetts Institute of Technology and Oxford University. And so I think he is well equipped to lead the overview of this first session. Our panelists include Dr. Ronald Summers, who is at the National Institutes of Health Clinical Center, Dr. Elliot Siegel, who's at the University of Maryland and the Virginia and Maryland Healthcare System and the NCI's Cancer Image Archive, Dr. Ella Kazerouni, who is at the University of Michigan Medicine and University of Michigan Medical School, and Curtis Langels, Dr. Curtis Langels, who is at the Stanford University Medical Center. Dr. Sorensen, would you like to begin?
Good morning, everybody. It's a real pleasure to be here with you at this conference, and I'm particularly grateful for Dan and the organizers for asking me to speak today. My name is Greg Sorensen. I'm a neuroradiologist, as many of you know, and I realize that I'm in a very distinguished group of scientists and investigators, and I feel a little bit like bringing coals to Newcastle. And in particular, as you will no doubt see very shortly, I know almost nothing about anything below the neck. And so this is all sort of foreign territory for me. But I have been spending the last 5 years spending a lot of time thinking about screening in radiology and in the challenges of bringing machine learning tools and artificial intelligence tools and automated, just quantitative imaging in general to the problem of screening for cancer. And knowing that, I think, is why I'm here today to try to think with you together about some of the challenges we face as a radiology community around the idea of advancing the performance, our performance, as we try to deliver care in the screening setting and using CT for the lung. But I hope to speak about things that transcend that and particularly identify some of the challenges and the hurdles that we faced. It's a daunting topic, but I think it's one that there are some pretty clear now data around, and I want to bring these to you in a, I hope, positive and helpful way, and with a lot of respect for the work that you and your teams are doing. I like to try to frame the question a little bit this way. Dan asked, what are the challenges and the hurdles? And I would say, what's the, one way to address this, I would say, is to ask you, what do you think is the most powerful force, the single most powerful force in American medicine today? And my glib answer to that is Newton's first law, which is inertia. There's just a tremendous amount of inertia in American medicine and actually throughout the world of medical practice. And there are some actually very substantial reasons for that. And if you are asking what are the hurdles that you're facing to roll out quantitative tools for image analysis to improve screening, I think let's think about the inertia we're facing and why we're facing that. Part of that, of course, comes down to resources, revenue, money, however you want to think about it. That probably plays a role. But I also think that American trained physicians especially are in fact very data driven and very experience driven. Just as a quick aside, one of my favorite lecturers when I was in medical school was the late Judah Folkman. And he was a very wry character, and he was explaining to us new medical students about some of the facts of medicine. And he said one of the most useful ways that we describe what we try to explain in American medicine is with the phrase, "we see this." Essentially, it's our experience. And you say, well, why do we give chemotherapy, or why does this cancer appear this way? Well, we see this. It's sort of essentially a cop-out, but it's also a recognition that the wealth of accumulated experience has something to say. And I think often physicians' intuition about why something works or doesn't work, why we're not changing, is an important thing to listen to. And some of that is human behavior I think we need to overcome. Some of that is actually well-deserved. And so it's that balance that I hope to share together with you today. Let's think specifically about some reasons for inertia, or as I might call it specifically, mistrust of these new quantitative tools or concerns about rolling them out. After all, if they were indeed the greatest thing since sliced bread, we would all adopt them in no time flat. And of course, we know that's not the case. So based on what we've seen with breast cancer screening, I would offer that there are 3 ideas that I want you to think about today that I've listed here. And I hope that we can apply them universally, but I want to specifically walk you through the data and why I think these are issues for us with lung cancer screening. First is we have to understand our own baseline performance in performing the task. I like to think about this as nobody wants to take medicine if they don't think they're sick. It's very hard to implement change if people don't think they need to change. And so we need to really be honest with ourselves around where our performance is and where it might be able to be improved medically, or else we're not going to make any progress. So that's idea number 1. We really need to measure our performance at baseline. Second, when we try to roll out tools, we need to be willing to measure and assess whether they're really improving things in the real world. And then third, I think there's quite a bit of variability in the way physicians practice, and we need to recognize that. It's easy to dichotomize doctors or humans into, oh, well, he or she is good at this or she's bad at that. It's not a good, bad thing frequently. So now let me take each of these ideas and move them a little bit deeper and apply specifically to lung cancer screening. And to start off, of course, you all know this far better than I do. Lung cancer screening really works. I was very pleasantly surprised when NLST reported its positive results back in 2011. And I was very caught off guard. I wasn't expecting it. Maybe it was 2010 when we first learned. And of course, this has been replicated now in other studies. I want to put this up front because a lot of the pushback that I have seen in trying to bring new tools to physicians in the breast cancer screening community has been interpreted by us radiologists, as somehow an implication that screening doesn't work. And that when we try to say we can do better, that we're somehow hearing that, we practitioners are somehow hearing that as a threat to the actual practice of screening itself, as if we're saying screening shouldn't be done. No, that's not the point here. But you'll see it's hard not to see this as the perceived reaction of people. And so as you think about how you're going to roll out new tools into your community, let's try to learn from the reactions that we've seen from the breast cancer screening radiology community. And I think this is important because humans are involved here. Humans are involved in the interpretation. And in fact, the whole point of quantitative imaging is that we can improve the human interpretation. So we have to measure that and see kind of what that delta is. So let's talk about that a little bit in breast cancer screening. I would say it's pretty clear that there is a certain reluctance amongst the breast cancer imaging community to measure and describe human performance. Perhaps it's concern that we will be giving our enemies some info. I don't really know, but the data have been clear for decades that there is wide variation in human performance. 1994 paper from Joanne Elmore showing a kappa of under 0.5. 2020 paper here just in January from the Google group that was looking at AI. And they, of course, did a reader study to measure against humans where they gave 6 humans a bunch of scans. And you can see their performance, their AUC 0.625, not particularly impressive. And the AI managed to beat that, which was, of course, important. But the thing I want to draw your attention to is this relatively weak AUC. Many in the breast imaging community, radiology, has said, no, these reader studies, and this is not the first study to show this, many FDA approval studies, numerous rigorously controlled studies have shown that human performance in interpretation against ground truth has this modest AUC. And there's been a lot of pushback. One of the few prospectively documented studies is DMIST, published back in 2005. And that also showed humans had an AUC of about 0.78. When you actually look at the self-reported literature, though, it's a different story. So, for example, the Breast Cancer Screening Consortium, they report 87% sensitivity, 89% specificity with a very high AUC. This is an AUC of over 0.9. They don't really want to admit that the gap between human performance is so big. When you really push, the folks who are really studying this carefully, they will admit that there are pretty big gaps in performance. Dr. Pisano was on a committee at the Institute of Medicine that back in 2015 reported that even in the BCSC consortium data, which is essentially doctors who are willing to have their own data analyzed, about half of them did not meet specificity or recall rate guidelines. You know, how frequently are we calling women back? So, and these data, there are good scientists involved in BCSC. I'm not saying that their science isn't solid at one level, but there's a strong gatekeeper bias that's hard to overcome if you don't prospectively enroll women. After all, the only biopsy results we get are the women who a doctor thinks should be biopsied. So what if they didn't get a biopsy? What if they moved to another state? We have no way of tracking those in the United States. And of course, when we look at baseline incidence rates, it can be hard to match this up. You'll see that the cancer detection rate here in 2007 to 2013 was listed at 5 per thousand. Most of us think that the rate is between 6 and 7 per thousand women. And so that would imply a sensitivity and specificity, or a sensitivity at least lower than 87%, probably somewhere in the mid 80s. It's hard to know exactly in screening mammograms what the cancer detection rate should be. DMIST, when they followed for 15 months, found 7.8 cancers per thousand. Most women, of course, go 24 months between screens on average, or maybe a little longer. And so you'd think that the cancer detection rate would be even higher. The SEER data suggests it's about 4.5 per thousand per year. So again, if it's every 2 years, you'd think that we're screening, you'd think it'd be about 9 per thousand. Wherever it is, that's of course an important thing, because if you think you're screening every year, well then maybe your cancer detection rate of 5 is awesome. So there's some controversy about this, but there's also kind of a lack of willingness to look at this. So for example, just this month in radiology, there was a paper out of Sweden that looked at their screening performance, and they reported a sensitivity of 73% and a specificity of 96%. But again, they were only finding 3 per thousand cancers. And when I looked to see why that is, they had created a definition that excluded any cancers found after a year. So essentially 2/3 of the cancers, they just didn't even worry about. And so they were only looking, they were using a much smaller denominator, which made their sensitivity numbers look much better. If you were to include the whole data set, their sensitivity data is more like what we see with DMIST and other supported studies, which is closer to 50%. So we have to look with a critical eye at what we're doing, or we're never going to be able to recognize why we need quantitative tools to improve our performance. So that's point number one. Point number two, when we implement these tools, we need to see if they work. As you know, BreastCAD was approved by the FDA with rigorous studies in 1998. It was reimbursed starting in 2000. Numerous vendors did very compelling FDA clearance studies and got FDA clearance with rigorous science. But that was in a laboratory setting. When we actually brought BreastCAD into the real world, it wasn't used as a second look. People were using it right up front. It was basically used off-label. And I think if you were to ask even the designers, they kind of expected some of that behavior. And so in practice, most doctors I talked to, when I came into the breast field a few years ago, said, oh yeah, I ignore CAD. I basically don't even pay attention to it. I only use it for medical legal reasons. And in 2015, Connie Lehman and a very distinguished group of investigators, again using BCSC data, identified that in fact, doctors perform worse with these quantitative tools. Why? It's very hard to know for sure. Maybe they leaned too much on them and it was old quote unquote AI that didn't work all that well. Maybe they were using them as first look when they were designed as second look. We don't really know what went wrong, but both anecdotally, which I think is important, but also now scientifically with this kind of data, the AI tools, the machine learning tools, and just in case you don't remember, in 1998, when R2 got approval, they described their software as based on neural networks. This was a neural network-based tool, modeled on neural networks. They're an artificial intelligence-based tool. So the idea of AI has been around for a long, long time, and definitely, there's nothing new there from a regulatory perspective. And yet, when we put this into practice, it didn't actually work the way we all intended. So that's my second point. You have to check the real world. Third, let's look back at those curves. And when we see the humans, and the curve on the left is from that Nature paper, the curve on the right is from some work we've done doing reader studies. Either way, you see each of the individual dots below the ROC curves. And it's on the purple, and the Nature paper, it's individual dots in our research, which will be published soon. These are the individual readers, but look at the difference on the right between reader number 1 and reader number 4 and 5. Completely different reading styles. One has a very low callback rate. Reader number 1, callback rate probably 5%. And so that's fantastic if you want a low recall rate, but only finds about half the cancers. The person on the right, the readers number 4 and 5, are catching 90-ish, 95% of the cancers, but they're recalling everybody. Which do you want? Well, we're hoping that this trade-off can be made. What does this tell me? It suggests that we don't need one kind of AI. We probably need 2 kinds of AI, at least, because there's different reader styles. We have to figure out how to help. Are the people, are they recalling too many people for biopsy, whatever? Or are they missing cancers? Different set of mindsets. We've all known since training that there are people who are overly cautious and there are people who move too fast, if you want to kind of hyperbolize these as readers. Why would we think the same AI would be perfect for both, or at least the user interface to the same AI? So in conclusion, I would say here are some recommended priorities for you to consider. Measure performance pre-AI. Take an honest look at it, whether that's under QA protection or whatever you need. It's harder than it sounds. In the breast, we have MQSA requirements to measure our performance, and it's still hard to get this data, despite mandates from Congress and resources to go into that. Second, when you start to roll things out in a pilot phase or whatever, please measure. Look and see if it's working the way you expect. Feedback is the breakfast of champions, and you've got to get some feedback on how things are going. Third, recognize that these are humans that you have to interact with, and consider trying to tailor your tools so that you'll boost adoption. Finally, I would just say I am trying to follow my own medicine. This is some data that from our own groups at RadNet. Each one of these dots is a different doctor. And you can see along the x-axis, I plotted their recall rate, and on the y-axis, their cancer detection rate. Here in light yellow is the IOM recommended range. So the doctors whose dots fall in this recommended range, these are the people who follow the guidelines. You can see we have a ton of physicians of the more than 200 doctors that we're studying here who don't follow the guidelines. I can tell you I've met this doctor. She's amazing. She has a very low recall rate, 4%, very high cancer detection rate, over 7%. That's who I want reading my wife's mammograms, I can tell you, because the reason that this recall rate is set, as kind of low as it is because you don't want to call too few women back at the risk of lowering your CDR. This doctor, she happens to be just really good, but for the most part, these outliers you do wonder about. Like for example, this person over here, recall rate 25% with a cancer detection rate of 4. What's really going on here? So we are trying to do this internally. It's not easy to get this data. We recognize it's going to teach us that we're going to have different approaches for different kind of doctors. Where does this go? Where do we go from here? Again, it's a challenging problem, but I think these are the challenges that I would bring to you. So in conclusion, quality and cost considerations strongly advise that as we move screening into the clinic, which we all know it works, this is not an attack on screening, but as we bring AI to try to make it better and faster, of course, cost and quality are super important, but there are some real human barriers and there are real sort of implementation barriers. I've listed again my 3 priorities. I won't go over them again, but I just look forward to the conversation with you. Thanks very much for your attention. I look forward to the Q&A.
Thank you, Dr. Sorensen. That was outstanding and particularly interesting to listen to the comparisons between breast. There's been an awful lot of work done over the years trying to persuade and encourage and incentivize breast radiologists to actually measure how good they are at finding small cancers. And it's really tough to get that engagement to take place. Why don't we open the discussion up to our panelists? They include Dr. Summers, Dr. Siegel, Dr. Kazerouni, and Dr. Langlitz. Dr. Summers, would you like to go first?
Yes, hi. Good afternoon, everybody. That was a great talk, Dr. Sorensen. Thank you very much. If the people at QIW could put my slides up, I'll just make a few brief remarks as a lead-in this session on the challenges and hurdles. Next slide. These are my disclosures. Next slide. I have an AI lab. I'm a radiologist and I have an AI lab at the National Institute of Health Clinical Center outside of Washington, D.C. Next slide. And we've been working at investigating many of the challenges in AI in body imaging. Some of the challenges we've been up against are limited data sets for training, the insufficient diversity of data that's available, the problem of domain shift where there are differences in patient populations or scanners that lead to difficulties of the AI system in finding the abnormalities on images from a different hospital or a different part of the country. The issue of multitask analysis. So many AI systems are focused on a single task, which reduces their clinical utility in a complex healthcare environment where physicians have to identify all the abnormalities on an image. And robustness in the presence of other diseases. And I'll show an example of that in one of the upcoming slides. One of the challenges, particularly for lung cancer screening, is that not infrequently, particularly in the smoker population, the underlying lung tissue is not normal. And it can make it difficult for the AI systems to correctly identify the cancers and distinguish it from other normal parts of the lung. And there's also quite a bit of anatomic variability from one patient to another. So for example, the images at the top show an AI system that had trouble segmenting the lungs on CT scans, but a deep learning system was able to segment the lungs even in the presence, for example, of ground glass abnormalities. Next slide. Another not uncommon lung abnormality in patients who are being screened for lung cancer is interstitial lung disease. This is an example from work at the National Institute of Health Clinical Center on interstitial lung disease label propagation, where there can be a variety of different abnormalities in the lungs, including emphysema, honeycombing, micronodules and ground glass opacities. And again, you could imagine how, depending on the distribution of interstitial lung disease in your subject population, it might be challenging to detect cancers. Next slide, please. One of the areas that my group has been working on is to try to identify all kinds of abnormalities on the images. And we've released to the public a data set called the Deep Lesion Data Set, which includes annotated lesions from all parts of the body, including lung nodules, bone lesions, liver lesions, and so forth. There are over 32,000 lesions in this data set used for training AI systems. Next slide. And using this data set, we've developed a universal lesion detector that doesn't just detect lung nodules, but also detects lymphadenopathy and abdominal lesions, which can also occur in lung cancer patients. Next slide. This shows an example of how the universal lesion detector that we dubbed Mulan did lesion detection, tagging, and segmentation. This program not only detected the lung nodule in the right lung in the image on your left, but it also detected the left adrenal gland lesion. In this case, it was an adenoma, but it could have just as easily been a metastasis from lung cancer, as adenomas are a known site of lung cancer metastasis. Next slide. There is an area of research ongoing now and gaining in popularity called opportunistic screening, where studies done for a primary indication, for example, lung cancer screening, one can also find other abnormalities that could improve a patient's health if detected early. This is an example of an osteoporosis detector that is detecting collapsed vertebral bodies, which can lead to morbidity in certain patient populations. Next slide. And this project, in a collaboration with Perry Pickard at the University of Wisconsin-Madison, published in Lancet Digital Health, showed how opportunistic screening of visceral fat, sarcopenia or muscle characteristics, liver analysis for fatty deposition in the liver, abdominal aortic plaque calcification, and bone mineral densitometry in the lumbar spine can help predict mortality and cardiovascular morbidity. And the exact same sorts of analyses could be done in the chest as well, giving such patients additional information at little or no additional cost. Next slide. What are some of the additional challenges? These include how to annotate data more efficiently, how to get multi-institutional data so that the AI systems generalize to different patient populations. Next slide. Thank you very much, and I look forward to the panel discussion.
Thank you, Dr. Siegel. Yeah, thank you, Dr. Summers. Can we have Dr. Siegel?
Yes, hopefully you can see and hear me. I'm really thrilled at the opportunity to participate in the panel. And if I could have my slides up, what I'd like to do is talk a little bit about my perspective as a radiologist that is involved with screening for CT lung cancer, and also in my role at the Department of Veterans Affairs, in addition to my role at the University of Maryland, where I've been involved in some planning for national screening, which the Department of Veterans Affairs is interested in. And one of the things that we've learned is that there's a lot of excitement and interest in AI applications for finding lung nodules on CT scans and characterizing them. But a comprehensive program for CT lung cancer screening really requires a tremendous amount of planning and forethought. And there's a lot of software that one can utilize for a program like this. So what I'd like to do is just talk about a wish list that I'd like for our software vendors based on our experience trying to do some implementation of the lung cancer screening. Next slide, please. So one piece of software that would be super helpful for vendors to provide would actually be software that would allow us to search through our electronic medical record for eligible patients, patients that meet the eligibility criteria for CMS, but also patients who are at higher risk in general. And it would be terrific to have the capability to have software go back into the electronic medical record and find those patients, and potentially be able to look at recent imaging studies, maybe months back, to actually pull out patients who have suspicious lung nodules and patients who essentially should be followed more carefully, even among patients who've already had their studies reported. It would also be tremendously helpful from a workflow perspective to be able to pull relevant patient information into a registry, such as the ACR registry. For example, information about date of birth, actual pack year smoking history, whether they have signs and symptoms of lung cancer. The things that are required for the registry should be done automatically, and there should be software that allows one to do that. The other thing is that utilizing databases such as NLST and PLCO allow one to be able to gather insights. And so one could use software, and we've developed some of this, that for each individual patient could create an individualized risk score. For example, Pacific Islanders have a 6-fold greater risk of developing lung cancer than Hispanic patients in the next 6 years. It's an insight from PLCO. And we've looked at the raw database from PLCO to be able to actually predict for each individual patient what their risk is. And so one could have a much higher yield, but lower cost in doing screening programs using that type of software. Next, please. Next slide, please, after this. And so another thing that I would very much like as far as software would be software that allows reconstruction of CT images. When we are using AI programs to determine the likelihood that a lesion is benign or malignant, we're using texture-based information. Most of the CT acquisition software that we're using currently is using iterative reconstruction, which is famous for destroying texture. And so the potential to be able to apply new AI techniques to preserve texture in CT is really exciting. The other thing that we've looked at is considering reconstruction at higher matrix sizes. We're all used to 512 by 512 reconstruction for CT. We've done studies and looked at data suggesting that higher matrix sizes, which are achievable by the CT scanners at 768 by 768 or 1024, would allow better characterization of these lesions and better analysis of texture and morphology. Next, please. The other thing that is important is to make sure that our software vendors give us access to software both locally and in the cloud. A lot of AI providers are providing software in the cloud only. Having mechanisms to consume locally as an option are really important also. Next, please. Integration is critically important. Whatever we do has to be part of our image review workflow or our reporting workflow. And that's not true of a lot or most of the AI software that exists currently. The other thing that needs to happen is that a server on site or in the cloud needs to take all relevant CT studies that could be eligible for AI application to screening and automatically identify those and do pre-processing on those. Next, please. So what's the functionality that I'd like to see in the software? Well, one thing I'd like for it to do, in addition to what the basic software does, which is to find lung nodules, and that's only a small part of the total screening process, is essentially to get a level of certainty or the reason that it is determining whether a lesion is benign or malignant. Software should allow me to be able to show agreement or lack of agreement. I should be able to interact with the software so that it gets feedback from me. And one of the things that I found really exciting in a recent lecture in a conference I ran called CMIMI for the SIM Society was Berkman Shiner from FDA talked about being able to have a system continuously learn. And so software needs to be submitted that not only has certain models out of the box, but learns that my VA patients are different from my University of Maryland patients, which might be different from patients in the Southwest US or another country. And so what I need also from my software vendors is to make sure that my database that I'm using, even out of the box, is similar to the database of patients that I'm going to be doing screening on. Next, please. Also, what I would like to have the capability of doing is ensemble and analysis, so that I might find that there are 2 or 3 or 4 pieces of software that I may want to use together. It turns out that humans do better with second or third opinions. It's true of software also, and I want software that allows me to combine those. I want to be able to track change over time. Most of the software that exists currently acts as though it's never seen prior studies, and being able to take into consideration, as far as probability of disease, even in a screening population, how things are changing or not changing is really critical. I also want software that allows me to track in a manner similar to mammography for lung cancer screening patients that I've identified as being at higher risk, and to essentially automatically interface with referring physicians to remind them about follow-up studies and remind them and patients about procedures that are recommended. I want automated reporting to a registry such as the ACR registry, and to have that happen automatically. I want my software to be able to have an error of measurement and to be consistent in measurements of length and volume. And the Kiva effort has been extraordinarily beneficial in identifying that, but adoption has been slower than I would like. I'd also like software to give me feedback on the quality of the scans. I'm doing a project now using AI and deep learning, looking at large numbers of CTs and identifying using AI which ones would be more diagnostic and considered better by radiologists or maybe AI software. And finally, in the future, what I'm hoping to do is a project that we've already started and use AI for this, where we're taking conventional chest radiography and replacing it with CT scanning at doses lower than conventional radiography, presenting the CT as though it were a chest PN lateral, but using the underlying CT data to be able to use AI to find lung nodules and do screening and other pathology. So I think that should be really exciting for the future. So thanks so much for the opportunity to present some of the needs, and hopefully we can have some Q&A to dig a little bit further into some of those topics. So thank you so much.
Great, thanks, Dr. Siegel. I think that's a really impressive laundry list of software needs. I think already many people already share those. So I hope we do have some opportunity to discuss what you think the barriers are to actually making that happen. Ella, are you up and on Zoom?
I am up on Zoom and happy to be here with everyone today.
Okay, great. Okay, so go ahead.
So I don't have any slides, but what I wanted to do is really have a conversation as somebody who is probably the least smart person on this panel. So when people say they like to be, do not want to be the smartest person in the room, that is definitely the way I feel with this group of experts and the knowledge and information that they're sharing with us today. But what I am is a cardiothoracic radiologist who is interested in clinical and translational research to drive the use of technology to improve practice. And for me as a cardiothoracic radiologist, I see chest CT as a population health tool beyond lung cancer screening. And we tend to think about radiology and population health as the screening test that we do, but it is so much more. I share the wish lists that have been described so far. And I wanted to emphasize a few points. I think we are so well positioned in lung cancer screening and actually cardiothoracic radiology practice in general in the way we use chest CT because of what we've learned from breast cancer screening in the past. It was great to see the work that Greg Sorensen presented about the human part of radiology and how technology can help improve performance. But like everything we've heard today, it's not so simple. As you've heard, there's different types of reader styles and they may interface with technology in a different way. But artificial intelligence and technology help raise the level of performance across practices and across readers, from people who may be 100% reading screening chest CTs to those who only read a handful a week and maintain the performance of the tool for our patients is critically important. For technologies integration, one of my biggest asks in lung cancer screening is to use our EMRs and artificial intelligence to identify patients for screening. And while that seems like it should be really easy, we're talking about age and pack years after all, it's not so simple. Smoking history and the medical record is essentially yes, no, and that's been driven by the early meaningful use criteria. And so practices did a great job of answering that question, yes, no. But the way smoking history is in electronic medical records is a challenge. Not only that, we know that patients have other risk factors for lung cancer. And while they're currently not integrated into the reasons why we identify patients for screening in general through the USPSTF criteria, there's so much more information in the EMR about a patient to help identify what their actual risk is for lung cancer. So as we move hopefully into a future area where we're using individual risk calculation to identify the right people who are at risk for cancer, taking into account other variables besides age and smoking history, being able to have a smart system that would integrate those pieces of the information in a way that doesn't require users to have to find some risk calculator somewhere and plug in information in a klutzy way to try and identify patients at risk for screening. Because you can only do well in screening if you can identify and bring forward patients to screen. And I see technology as a way to start at the foundation, which is identifying those who can benefit. But I also see it as a way, at a patient-centered way, to identify people who are patients that have that are likely to come forward for screening, even if you were to offer it to them. So we know through much of the information in the medical record, information about people that indicates whether they are prone to health maintenance behaviors by actions that they take, by information that we record, by whether they exercise, by whether they come forward for other screening tests. So we can also look at the characteristics of individuals and their willingness to undergo health maintenance and screening behaviors as another form of identifying people who are most likely to come forward for screening should it be offered. So I think about it as not only a risk factor identifier, but a patient identifier and a way to characterize patients. When we get to the radiologist as a reader of these examinations, it's complex. And it's been stated, we interact with data in many different ways. And fundamentally, for a user, I want a seamlessly integrated system that helps identify candidate nodules, that is easily interacted with at the workstation to reject or accept, to record why readers might think something that was identified isn't something that should be concerned about so that we can understand it in the future, and to help us seamlessly integrate all that into our reports, both back to the referring physician and their physician teams, but also to the patients to be able to create patient-centered reports. I want it to help detect them, and I want to help it tell me what nodules I need to worry about, I'm concerned about, based on other factors about the patient. It's not just the nodule characteristics that define the risk for that patient actually having cancer. It's other things we see in the images, background emphysema, potentially other things in cardiovascular disease, as well as things that come with the patient, like their occupational and environmental exposures and family histories. So we go into a screening CT, identifying them, we can determine their pre-test probability of having lung cancer, but we also can have a post-test probability based on what we see, whether it's growing, lots of other features, and that should be easy information that we can then use to translate to our referring providers and patients in a way that's meaningful. Your pre-test probability is X, your post-test probability, because of your individual patient characteristics, is this much, which might be different than another patient who has the exact same imaging finding. And we don't have a way yet to translate all of that information for patients. And then I would say the third big bucket for me is management of patients. It seems so easy. You read a lung cancer screening CT, you get through finding the nodule accurately, characterizing the lung RAD score, which partakes with at risk, and you make the recommended management. But how do we make sure that management actually happens without complex reminder systems and people going in and out of the EMR and building clunky work lists? Is there not a way to harness the data that's in the EMR and how patients like to communicate and referring providers like to communicate to make sure that we're making the communication in a way that's well received and so that it sticks and patients get the recommended follow-up that they need to make lung cancer screening have the impact on mortality reduction that we're seeking? And how does it facilitate? How can we create an EMR that is tailored in the way it appears even to our patients, based on the way they interact with it through the patient portal or telephone visits, whatever they interact with it, so that when we are doing patient-centered communications of information around screening or frankly other radiology tests, that they are receptive to it in the way that we push it back out to them and we communicate with them. So those are really my three big buckets: the identification of the people at risk, the interpretation component and how we can improve it, and then the management component. I am so grateful to the work that's been done in breast cancer screening, because I think because of it, because of reader observer studies and trying to improve performance, we can accelerate that work much faster in lung cancer by lessons learned. I think we have made such great strides in the ability to extract the lungs, define pleural surfaces, pull out the pulmonary vessels, that we've reached a pretty good mature state in some of that. But what we haven't done is taken the work that's been done and made it seamlessly usable in a way that we can impact the patient care that we're delivering so that we can get to meaningful outcomes. So that's my take on some of the use of technology in lung cancer screening, but also about chest CT as a population health tool. I want to make sure that we don't lose that piece of the conversation by identifying emphysema, compression fractures that increase patients' morbidity and mortality, particularly if they have lung disease, cardiovascular disease. We can make a much bigger impact than simply lung cancer alone. And we can do that not just with screening CTs, but with every chest CT that we read. So thanks for a few minutes of your time this afternoon.
Great. Thank you, Ella. Thank you. That was outstanding. Dr. Langlois, why don't you go ahead?
Great. Thank you, Bob. It's a pleasure to be here with you all today. I just first want to start by congratulating Dan on receiving the Molshine Award. I listened to the tribute this morning and to Dan's inspirational personal story, and I just thought that the tributes were incredibly on target. So I just want to add my congratulations. And so Dan, thanks for your leadership. I knew based on the panelists that they were going to cover the map and in terms of issues. And so I want to focus on just a couple, drill down a little bit on a couple of issues, and then happy to answer your questions. My disclosure, so I advise several AI startups. The center that I run and my School of Medicine receives support from several other companies, and I serve on the board of directors of RSNA, and I hope that's part of why I'm here today, I think, is to give the perspective, not just of the work we do at Stanford, but of the RSNA. So I'll start with these two white papers, which were the result of an NIH workshop that was supported by the RSNA, ACR, and the Academy, to look at a roadmap and develop a roadmap for both foundational and translational research on artificial intelligence in medical imaging. And a number of conclusions came out of that, but one of the more important ones, which has been mentioned, is the need for publicly available, widely available data sets for training of these machine learning algorithms, which require large amounts of labeled AI-ready data. And that's something that we've really paid close attention to at our center at Stanford. We've released 8 data sets you see here, many of them cardiothoracic, in fact, and more in the pipeline. But I think that we need much more of this, and we need more multi-institutional data sets in order to train more robust algorithms. One of the ways in which these data sets can really drive progress is through challenges. And the RSNA has led a series of annual data science challenges, starting with bone age 4 years ago, then a pneumonia detection challenge, followed by last year, an intracranial hemorrhage detection challenge. And just to give you an idea of the engagement, this data set was over 27,000 EdCTs, comprising over 1 million images from 4 sites across 3 continents. They were labeled by volunteer neuroradiologists, selecting one of 6 labels. The data set then was attacked by over 1,300 data science teams that submitted over 22,000 entries for this prize money of $25,000. And you can imagine the number of highly functional algorithms that came out of that competition. So this is a good way to drive new methodology and new capabilities. This year's RSNA challenge is a pulmonary embolism detection challenge, which the winners of which will be announced at the annual meeting next month. So I think that's a very important way to drive progress in any field. And I think, to consider a lung screening challenge would be another important sport. This is some work that we recently published in JAMA, just analyzing where the data comes from that we use to train our deep learning algorithms. And unfortunately, it's not as diverse as we would like. Most of it comes from 3 states, and you can imagine that states obviously have unique demographics and many other characteristics that don't necessarily generalize well to the rest of the country or the rest of the world. And so this is really something that we need to work on, just in the way that not only the way we frame questions, the way we collect data for questions, and how we answer those questions, because it can lead to unintended biases in the capabilities of the algorithms that arise from those data. I think one of the antidotes to that problem is represented by a new NIH-funded effort that I was privileged to be a part of. This is a collaboration between 3 of the major imaging societies, the RSNA, the ACR, and the AAPM. And when 3 organizations like that get together and all rowing in the same direction, you can imagine we can make progress very quickly. And this has some ambitious goals. So first of all, it is intending to aggregate and planning to aggregate 60,000 cases of COVID-19 imaging studies released in the first year. There are 5 infrastructure projects that are developing the capability of ingesting, de-identifying, labeling, storing, making public available these data sets come from all over the country, all over the world. There are 12 associated collaborative research projects that are developing AI algorithms, capabilities, labeling capabilities that facilitate the development of algorithms for COVID-19. And these are based on organizations all across the United States, so it's a much more diverse data set. And actually we have data coming from around the world. I also just want to mention the RSNA technology stack for artificial intelligence and structured reporting, which I think will be, as Ella and others have mentioned, as a critical part of screening. And you can think about it as a kind of spectrum. So at the top, we have the RSNA report template library at radreport.org, which is, if you can think of an analogy to DNA, that's kind of the complete report template, the whole document, and how you might organize the thinking around a particular clinical case. And then we have data elements. So these are particular sentences, you could say. It's maybe a question and a set of answers. BIRADS in the breast is like that. What is the BIRADS code? Is it 1, 2, 3, 4, 5, 6? So those are the molecules that make up the report. What are the characteristics of the calcium, for example, or the margins of the mass, and the various possible responses to that question. And then the terms, which are just the words or phrases that make up the sentences and ultimately the reports. And that's RSNA's RADLEX terminology. The Data Element Project is a collaboration with the American College of Radiology. And the RADLEX, we've collaborated with many international organizations to translate that into other languages. I did want to close with just one screening project. In the subtitle of this workshop, I notice is cardiovascular. So I wanted to just get away from the lung for a moment. This is work that's going on in our center by Bhavik Patel and some of our computer scientists from Andrew Ng's lab. On the left, you see a gated CT where we're trying to freeze the heart, and you can very nicely see the calcium in the coronary arteries, which is, of course, by quantitating that, we can get a sense of the patient's cardiac risk factors. But we have, and that's of course a dedicated study, but we have hundreds of thousands, millions of patients every year who are receiving routine CTs for other purposes, which are not gated. but we do get a view of the heart. And you see there, the calcium is somewhat smeared across the image because of the motion of the heart, but we can use AI algorithms to enhance that and to quantify it. And when we do that, we can actually create a risk stratification algorithm that we could apply opportunistically to anyone receiving a CT for any purpose, and not just those who are paying whatever fee is required to get a dedicated gated CT to assess the coronary. So I think that's an important, this kind of opportunistic screening will be an important element of screening programs going forward. So I'll close there. I hope I've given you just a little more detail on some of the key areas that I think are important for screening going forward, and how we support those at RSNA and at our center at Stanford. So thank you very much.
Thank you, Kurt. These were really outstanding presentations, and I would love to actually pose questions to all of the speakers for the rest of the afternoon. We have a little bit of time left, and I'm wondering if any of the panelists actually would like to pose an issue to each other. I think we heard some really, clearly summarizing themes, beginning with inertia, which is something we all grapple with, is that it's hard to see why things aren't happening faster. And then two of the speakers identified a long wish list that it always makes me wonder, if you want these things and they would make your jobs easier, why don't we have them? And this ranges from everything from identifying the patients at risk through electronic health records that, in fairness, as Ella pointed out, were never designed to actually have that information. But it's been a number of years since we've known we needed it, and we still don't have it. So the question becomes, I think, how can we overcome these barriers and to a certain degree this inertia? The examples with breast, I think, are very timely, and they're relevant, because really there's quite a few radiologists who would tell you they don't like reading mammograms. They don't like reading screening mammograms, and they might really welcome an artificial intelligence approach that would leave it to them to do diagnostic evaluations and others. The issue with CAD is really quite apt. The radiologists who really relied on CAD were inexperienced, they had low volume, and they were not people who were at the top of their game. People who are at the top of the game have replaced double reading with CAD, found that there was no deficit in their performance. It's just the radiologist that doesn't much want to read mammograms that can't use it very effectively because it's really not designed that way. So I wonder if, perhaps Dr. Siegel, Dr. Kazruni, if you could just speculate as to what it might take to get these tools that would make your day-to-day much easier.
I guess from my perspective, there's a long wish list, right? People want a lot of things. And if we don't prioritize what those things are, it's hard to drive the resources, whether it's in health systems or research labs or industry, to conquer those first challenges. And as you've heard, so many possibilities and so many things we can do. What can we do that would have the greatest impact for the patients? Because at the end of the day, it's about improving patient care, reducing lung cancer mortality for a patient population. And as an example of that, I'll use something that was mentioned about coronary calcium and finding a way to freeze motion. Well, that's great. It's a great research idea. It's already been shown in NLST that if you take NLST CTs, which we're talking about exams that were acquired a long time ago by today's standard on older scanners that were a little bit slower than what we have today, and you code them using a very simple system, none, mild, moderate, severe for calcium, that correlates with the Agatston scores that have historically been used for calcium scoring on CT. So how much better do we need to be than that to have patient impact? So it's just an example, and I think it's great work that it's being done, what you described, Kirk, but what do we need to do to get to the goal, as opposed to working on things that may not necessarily help us improve patient care as quickly? I think we need to hold that first in making choices in targeting resources and prioritizing.
Yeah, so one of the next steps that we're taking with that is a prospective clinical trial. So what happens when we provide that information to patients? I think that that's going to be the way that those who are caring for the patients actually begin to believe that that information is going to be helpful to the care of patients. So, I think that's, generating evidence, generating trust. Those are really important aspects of what we're doing.
And if I could take a crack at the barriers, I think there's a tremendous opportunity for a cultural shift. A lot of the software that's been provided has been sort of one-up software that finds lung nodules, software that identifies the likelihood of a nodule being benign versus malignant. But I think we need to take a much more holistic approach. I think if we took an approach where we tried to have an entity create a solution to lung cancer screening or to COPD or to lung malignancy as a disease, when you start taking a comprehensive approach, then you start coming up with software that allows one to go soup to nuts, identifying patients that would be appropriate, optimizing scan quality, optimizing the ability to be able to do reporting. And so one thing that we need is to start thinking culturally from our vendors in terms of solving clinical challenges and clinical approaches. That's why I think conferences such as this are so incredibly valuable, because we're looking at it as an entity of CT cancer screening rather than specific small aspects of AI. And so I think the earliest versions of AI inevitably will be software and algorithms to solve specific problems, finding lung nodules, characterizing them. As time goes on and the market becomes more secure, we'll see holistic approaches where entities treat entire disease entities or entire screening challenges. And I think at that point, that's going to lower the barrier and will accelerate significantly faster, because those entities will be looking at solving multiple challenges that we have simultaneously in an integrated fashion.
I'd just like to add, Bob, making the jump from tools that have been developed to integration and practice requires resources. And there is really no funds flow model yet in the radiology health enterprise to provide the resources to do this additional work, to integrate these additional tools, to acquire these additional tools into the work we do. Somehow it seems to be assumed that these are all good tools, yes, and that you can just throw them at a practice and magically, poof, they're going to work. We have not yet found a funds flow model in imaging that helps support practices making those investments to make these tools usable. And that is that's a real financial obstacle, even if we prove these tools work.
And I think
go ahead.
Yeah, I was just going to add to that. One area where work is ongoing is that if you look at, say, the RSNA AI showcase last year, there were 130 companies all building AI algorithms in that area. And then you've got dozens of PACS vendors and you've got speech recognition vendors. And so how are all of these 130 companies going to deliver their results into clinical workflow in a way that makes sense for the radiologist that can be consumed? And so there is actually good work going on in the standards area. It's a lot of plumbing, so it's not worth getting into the details. But those standards are being developed so that it's not just a one-off between this vendor and that vendor, and they connect together. There are some standard ways in which results can be delivered. And if all of the companies work towards those standard methods, then you can kind of plug and play, just as we do with DICOM. If you have a scanner from one vendor and a PACS company from another vendor, you can still, look at the images. So that work is coming. I think it'll help reduce the cost, but I still agree with Ella that you need to have the right financial models. And then the other aspect I think is really important is, getting back to trust, that you have algorithms that may be developed on data sets in one area or from one institution or maybe a small number of institutions. I know when we think about this as a customer, we're not assuming that algorithm is going to work in our setting. We need to validate that, and in fact, to continue to monitor it over time so that we are assured that has the appropriate accuracy, the appropriate parameters, performance parameters for us, and that they don't degrade over time if we add new devices and so on. So I think that aspect of it also is incredibly important and also expensive.
Yeah,
It's not just a shrink wrap.
This is a conversation I hope we can continue. We are past our time, so I'd like to thank all of the panelists for really provocative and outstanding presentations. I thought the give and take between you all was really excellent and really benefits the meeting. Dan, I'm going to turn it back to you.
Thanks, Bob. Yeah, it was a wonderful discussion, and I think the next session will pick up and continue some of these topics. I'd like to mention for the panelists who we just heard from, there are several questions in the Q&A box that we didn't get to, but if you have a chance to look at them, you might want to respond to the people in the Q&A section. A couple of questions might come up in this next session. One is on how do you handle intra and inter-observer variation in ground truth for AI model training, and another one about the difficulty of getting images from institutions in order to create the necessary database. So in this session, we're going to start with an overview talk by Mary Ellen Geiger. I'm going to be very brief with the introduction so we can try to preserve as much time for our speakers as possible. Mary Ellen is a professor of radiology at the University of Chicago and has a long track record of work in AI. Mary Ellen?
Thank you for inviting me to speak at the Prevent Cancer Foundation Quantitative Imaging Workshop of this year. I've been asked to talk about metrology and quality assurance perspective of what are the challenges and hurdles hindering the validation and regulatory approval of AI algorithms for CT screening. Here I list my findings and conflict of interest of grants and others, as well as the University of Chicago policy. Now, to consider the challenges and hurdles, we first need to understand metrology and QA. Metrology is the scientific study of measurement. We will need to consider performance metrics of the AI algorithm by itself, as well as the AI algorithm when it's being used by radiologists. That is, what is the performance metrics of evaluating the radiologists when they are using the AI algorithm? One needs to look at validation methods, and all of these are to appropriately get through regulatory approval or clearance. QA, quality assurance, is the maintenance of a desired level of quality in both the input data, the images, and in the AI algorithm. Performance of the AI algorithm across different populations, different medical institutions, different image acquisitions, and so on needs to be considered. And we also need to consider quality assurance as we continue performance evaluation post-regulatory approval or clearance. So for this sessions, the discussion objectives given to me are, what are the major challenges for a developer trying to bring an AI product to commercialization? How important is rigorous QA for that input data? And what will be the APM's role in MIDRIC? So let's consider medical image interpretation. Medical images are meaningless grayscale color scale patterns unless viewed and analyzed by an intelligent observer. That could be the radiologist, the computer, or a combination of the human and the computer. That is AI aided. The task of the human eye-brain systems are finding and localizing a signal in an image, characterizing, classifying, or diagnosing the signal as disease or non-disease, and also clinical decision-making on patient management through integrated diagnostics and monitoring. The task of AI is very similar. Basically, we're converting images to quantitative values. So very similar to the human eye-brain system, and very important to know what is the clinical task when developing an AI algorithm. And this is important to note. The AI algorithm, shown here, is basically the computer algorithm that exists in a system to take the images, process them to answer some biomedical question. How they are used is also important. For example, computer-aided diagnosis is one such method. We need to consider, will the AI be used as an aid to the radiologist? Will it be also used as an aid or as a concurrent reader? Could it be used as a primary reader in triaging, or will it be totally autonomous AI? We'll talk more about that later. And note, this still does not specify whether the AI is to help interpret an image or to also integrate it with other diagnostics. So what are the major challenges for a developer trying to bring an AI product to commercialization? Well, going from the idea to the lab investigation, proof of concept, maybe translation, getting an FDA product, installing that product, and getting it to actual widespread clinical use is a long path. Many papers out there are at this stage. It's a laboratory investigation done on perhaps an independent data set. Some might get translated, and then the rigorous of going through the FDA is quite strong and quite beneficial, because that demands many of the aspects that I will mention here. The developer needs to understand the clinical task. Are you looking to detect or diagnose? Are you looking at response to therapy and using multiple images over time? Are you going to be using AI as an additive component in the decision making, or as a replacement in the decision making? And are you developing the AI to improve the performance of the interpretation task, that is the efficacy, or to improve interpretation times, for example, and that would be efficiency? You also need to understand how the AI algorithm will be used in the clinical task as a second reader or a concurrent reader. Will it be used as a triage or to rule out normal cases? Or will it be used as an autonomous reader? These are questions that you need to answer prior to the development of the AI algorithm, and definitely prior to the evaluation of it. In developing, you need enough data. Data could be the images, the clinical data, as well as any annotation of relevant disease or tumors and non-disease regions. You need to consider the number of cases, and not just the number, but the distribution of cases, the disease type, the severity, acquisition protocols, as well as various populations. You also need to ask yourself, who will ultimately use the AI algorithm? Will it be radiologists or will it be primary care physicians? Will they be an academic, private practice, both? And what range of training of the ultimate end user will be necessary? And then after that, you have to come up with an appropriate performance metric for the clinical tasks, such as ROC analysis, sensitivity, specificity, and others. All of this will impact both training and testing. Now, once you have FDA approval and clearance, there are still challenges to bring your AI product to market. You will have to integrate your AI algorithm into a clinical IT backbone or cloud. You have to look at disaster recovery, HIPAA IT security issues. And a big issue that I think many do not think about is the potential for the end user, the clinicians, to use the system off-label. It might be intentionally. That is, maybe it's an FDA cleared second reader AI system that they are going to use as a first reader. Not allowed, but might happen. Or it might be used unintentionally. That is, it was approved for a specific imaging protocol. They have an image, similar but different protocol, and they input it and the system doesn't work. What happens? And I think it's very important to remind the end users, garbage in, garbage out. We use garbage in, garbage out when we're trying to have people train appropriately and test appropriately, but also that needs to be when used appropriately. And these challenges are not new. Let's look at what's changed with AI over the decades. We have faster computers, larger data sets, more advanced algorithms, including deep learning. We have the realization of additional reasons and means to incorporate in clinical practice, and it's now being developed for more and more clinical questions. However, the clinical task of detection, diagnosis, response assessment, those broad ones are the same. We have the same concern for garbage in, garbage out, the same potential for misuse, same methods of statistical evaluation, same need for a sufficient number of cases to span the distribution of disease and normal presentation, and same need for imaging domain experts and computer domain experts to work together. Second objective of the session is how important is rigorous QA for the input data? That is, how, or I should say, can big data overcome the issue of input data heterogeneity? Well, one way is, do we train with heterogeneous data? And we also have to think about diagnostic quality and good image quality. When radiologists read, they may get an image. It may not be the best image quality, but they will say, I can still make my diagnostic decision on this image. So it is of sufficient diagnostic quality, but may not have the best physical image quality. Do we train our algorithms on AI for that? We definitely will need to test them on those. So we can ask ourselves, should we train with bad data? Should we train with bad data to mimic clinical environment? So when we look at databases and quality assurance, we can look at the differences in image acquisition or population. If we look at different image acquisitions, we have to consider different spatial resolution, noise, and system gain. Now, out there we have big data, which is standard of care, which will be very variable. We have data from clinical trials, medium size, and we have small data. And often with AI development, people are developing with a very focused small data set that might be very carefully obtained, but ultimately it's going to have to be used on standard of care images. Population may affect the computer extracted phenotypes and the AI algorithm, such as disease prevalence, geographical variations, single versus multiple institutions, and lack of harmonization of the data. So this is so important, I'm going to repeat it again. The size and distribution of the data set will depend on the task. So if you have a very easy task, you won't need that many cases. And if is it a binary yes or no type decision, or does it span multiple severities of the disease? That will also influence the size and distribution of the data set. And also the quality of the annotation and truth. If you get your data from multiple places, maybe one institution is very careful about reading that pathology report and the other one isn't. So it's always good to double check the truth. Here's an example that Whitney looked at in attempting to harmonize MRI radiomic features across two data sets, one from the US and one from China. She used the combat data harmonization feature. And if we look at this, these are cancers where the cancers from the US are in red and in China in orange. And this is one particular characteristic that one can pull from the image. And you see by after harmonization, the distribution of the two features can come together. This was also shown with benign lesion, that doing harmonization was able to bring the two distributions more harmonized. But how does this affect performance? Well, she showed that if you do this and then retrain, the pre-harmonization to the post-harmonization improves the classification ability. Now, this was in malignant and benign breast images, but it shows that you can do some harmonization of features. And in this case, potentially, would you have one algorithm for both institutions? Well, she's still checking on that because perhaps harmonization might not work. And you might need AI tuned to specific populations, specific institutions, specific acquisition systems. I think when it comes to this heterogeneity and trying to harmonize a batch effect, you can think of the batches as this batch came from one institution, this batch came from another institution, this batch came from maybe the same institution, but a different CT scanner. And of course, as mentioned earlier in the day, recall the discussions on QIW. And third, I was asked to comment on the AAPM's role regarding QA of data in MIDRC. So MIDRC, as you might have heard, is a new NIBIB funded initiative. It is called the Medical Imaging and Data Resource Center. It is, I am the PI of it, and is hosted at University of Chicago. It is co-led by APM, RSNA, and ACR. And this is because of the COVID-19 pandemic. We need to develop new methods for surveillance and early detection, for triaging and differential diagnosis of COVID-19, as well as prognosis, including prediction and monitoring of response. So this effort is for the rapid and flexible collection, AI research, and dissemination of imaging and associated data. Two major components of it is to create the open discovery data repository, including creation, testing, quality assurance, and data connectivity, and machine intelligent computational capabilities, clinical relevant algorithms, and software tools. This is the flow chart of it. Data intake will be between ACR and RSNA, going up into a data commons, which will then be shared with users. The APM's effort is on developing and implementing quality assurance and evaluation procedures for usage across MIDRC. You see here across is the APM Technology Assessment Guidelines. This is for image acquisition and protocol harmonization. There are two major parts of it, is development of digital and physical imaging phantoms for COVID data and assessment of image quality on ingestion into the MIDRC. And there's also the APM's role in technology assessment, metrology, benchmarking, and task-based distribution for evaluation in order to expedite the evaluation of developed AI algorithms to the public. The development of benchmarking methods for the various technology assessment and clinical tasks in COVID-19 research and translation are needed and will be investigated, and the development of task-based distribution methods. Both of these are being developed to facilitate FDA clearance and accelerate clinical usage. Methods of selecting clinical cases for independent testing are required to appropriately evaluate a validated algorithm. And for specific tasks, for example, diagnosis of COVID-19 from other presentations of pneumonia, a distribution of cases matched to a clinical claim and intended patient population will be randomly drawn from a larger sequestered data set within MIDRC and subsequently used in the testing. So we've covered these discussion objectives, and I look forward to the various input from the panelists. In summary, the ways to use AI in clinical interpretation is expanding every day. We need to keep in mind that we need to evaluate it alone in the particular task, and also we need to evaluate the end user. We need to look over the robustness, over the range of data quality, make sure it's being used as intended. High-performing AI used for the wrong clinical task or incorrectly by the user will not yield expected clinical outcomes. And we need to realize that AI output is not always correct. And so we need to ask, what level is acceptable for clinical use? How will it vary with the task? What is the cost benefit? And what level is high enough so explainability is not needed? I'd like to thank my lab of wonderful graduate students and research lab staff and collaborators. It's a wonderful collaborative experience. Thank you.
Thank you, Mary Ellen. We're now going to have several panelists to elaborate on some of the topics that Mary Ellen introduced for us. And the first panelist is going to be Nancy Obuchowski, who's a biostatistician at the Cleveland Clinic and has worked with us on metrology issues in QIW for quite a few years, and now is working with a group on some of the more complex issues related to metrology. So, Nancy?
Well, today Dan asked me to talk about validation, particularly in the area of multi-parametric imaging biomarkers. Next slide, please. This is a really broad area that QIW has been working on for about 2 years. And because it is so broad, we decided that really it should be broken up into use cases. And we've identified 4 use cases, which are described here in the rows. So I'm just going to go over these real quickly because it will help you see where we're going with validation. So the first use case is the multi-dimensional descriptor, where here we have a panel of individual but related quantitative imaging biomarkers, each of its importance. The second one is phenotype classification. And here the idea is you take multiple QIBs and put them together in a model to classify cases into phenotypes. So an example would be if I had several CT biomarkers and I want to build them all to classify liver lesions, the phenotypes would be, is it a cyst or a hemangioma or METs? The third use case is probably the one that's most familiar to people. It is it's called the risk prediction, where I have multiple QIBs and I put them together in a model. I want to predict a patient's outcome or their risk. And then the last one is radiomics, where we are extracting kind of derived metrics from an image for predict as well. Next slide, please. So I want to talk about quickly about use case 3 and about validation. So let's suppose that we have a prognostic tool that we have built, and we're going to use, and we've built it based on quantitative CT imaging biomarkers, and I've listed some potential ones here. So what we need to do is we need to establish the performance of the model. Now, many of us are familiar with terms like cross-validation and bootstrap validation, these approaches. So these approaches are great for when you have a training set and you're trying to select variables and tune your model, but that's not what I'm talking about here today. Today, I'm talking about how do we validate the lockdown tool, the lockdown model? We've already done developed the model in our training set. We need to validate that lockdown tool. So what are the issues in this external validation? Next slide, please. So I've listed 5 issues related to this external validation. The first one is kind of the elephant in the room. It's the availability of validation data sets. And I tell these 2 descriptors to that validation data set. One is we want it to be generalizable. Of course, we want it to be generalizable, but we also need it to be independent of the data set that we use to build the model on. Not only independent, but now we have these terms. We need it to be spatially and temporally independent. So we are expecting a lot from this validation data set. Another issue is missing data. There's no doubt that when you get this validation data set, no matter how rich it is, there's going to be missing data, variables that you wanted to put into the model to build your model that aren't going to be there. So imputation is a great approach, but too often I see investigators using the lockdown model itself to help with the imputation. And that is, really cheating. So you can use, other patients in the study that are similar to that patient, but you can't use the lockdown model itself for the imputation. Another issue that we're all familiar with is the reproducibility or lack thereof of the biomarker measurements. So you can imagine that you're in your training set and you have lack of reproducibility in your biomarkers, and we recognize that. But now imagine taking that tool and taking it to an independent data set, a data set that was created at a different site. We're going to have even greater reproducibility issues. So one way to get around this is to make sure that in the training set, we have vetted different scanners and scanning protocols so that we've seen the range of variability, so that we know that when we go to the validation data set, we know what to expect there. The fourth factor issue is one that Dr. Geiger just mentioned, and that is batch effects. And she did a great job describing what that means. It's when in the training set, you have differences in the distribution of the QIBs. And if the outcomes in the different sites are different, then you can have associations between the input and the output of the model, which aren't real. And of course, when you take that to the validation data set, you don't get anything. There's no association there. And she described really nicely how to correct for that with this pre-processing of the data. And the last thing that I want to talk about is timing of imaging. And this has been something that I've been starting to really investigate, particularly for these multi-parametric biomarkers. So sometimes you have multiple biomarker variables that go into the model, and they're all measured at the same time from the same scan. So that makes it all the measurements are correlated. So if there's problems with patient or with image quality, they're all affected. And so that's one issue. But another related issue is when the images are acquired from different scans, and particularly when there's time difference between those scans. And particularly, it can be compounded when the first scan, we look at the results, and that affects how we perform the second scan. And so these are factors that really need to be taken into account in the training set. And then we need that validation data set to be so rich as to include these dates and how maybe one scan was affected by another. These are all really important things for the validation data set. Thank you.
Great, thank you very much, Nancy. And it's a complex topic. We wish we had a lot more time for you as well as some of our other panelists. And we're going to have 3 panelists now in a row, all of whom have been involved in developing AI, sort of in the technical development aspects. And each of them is going to touch on some different types of challenges that, again, that Mary Ellen introduced early on. So the next panelist is Rick Avila, who is a computer scientist and the CEO of Acumetra LLC. Rick.
Sure, thank you, Dan. Okay. Well, first I want to just mention that I've been studying artificial intelligence since 1987, when as a student, I actually joined a group at Open University in the UK and got started back then. So I've seen quite a lot over the decades. And after that, I actually spent a lot of time in a neurobiology lab looking at computational opportunities for working with real neural nets. And I have a lot to say about that. But for this talk, I'm really focused here on issues with the published literature on AI, particularly with respect to lung. If you go to the next slide. So one of the questions that's been kind of haunting us for a while now is, are we improving in terms of detecting lung nodules within CT scans, CT screening scans, for example? And the bottom line, unfortunately, is that it's very hard to tell. I think we are improving, but there's a lot of things that are getting in the way of making that declaration definitively. So to help you sort of understand why I say this is, I'll just go back to a slide I created back when I was leading GE's, whoops. Okay, I'll go back to a slide I created when I was leading GE's computer-aided detection area out of GE Global Research in a former life. And at the time I was really frustrated because with a really high-end computer vision group with statisticians and others, we had created the first computer-aided detection method for all types of lung nodules, including solid, part solid, and non-solid. And we were getting what we considered to be pretty good performance for that. But in the literature, there were groups that were presenting every possible combination of, actually good combination of sensitivity and specificity. And so at the time I needed to communicate to everybody that when they do that, when people publish their results, as many speakers before me have mentioned, you need to take into account a large number of things, including, how many cases did they use, what was the sizes of those cases, what was the size distribution, et cetera. And I'm not going to walk through all of these elements. This was again back in 2003. But if you want to compare apples to apples, you have to nail down a lot of these things between two algorithms and how their performance was created. So 20 years, not 20, but 17 years later, and over 20 years, I started on lung CAD about 20 years ago. The same issues are still there, and I think Mary Ellen and Nancy covered this, but I'll just do it really quick. Overfitting back 20 years ago, we worried about overfitting. If we saw an algorithm that had, let's say, dozens of features, and the classifier took those features and generated a result, you always worried about overfitting, basically finding some pattern in those many features that would not hold up over time. And especially with AI algorithms, because we don't really have a good understanding of what they're doing inside. We're getting better at that over time with different mapping methods for seeing what the weights are inside of a deep learning algorithm. We still run the risk of overfitting, and but it's even harder now to understand if that's a major part of how a performance is reported as high as it is. We still have issues with small data sets. We still have issues with lack of diversity, as these were all mentioned earlier. Scanners, patients, diseases can be present. I have to warn, I went through all the recent literature and went back 10 years, and most, even the data that's available now is working with old data, data from NLST and LIDC and IDRI. These data sets were created more than 5 years ago. Many of them more than 10 years ago. And we're talking about major changes in CT scanners and CT reconstruction and CT detectors and other things. So that leads me to rapidly changing imaging technology. I mean, we're past the threshold of adding AI to the recon algorithms. So how is AI going to perform when AI is involved in the reconstruction? Well, we got to go get the data, and that's going to take hopefully not 10, 20 years before we have enough of it to really get a significant amount. Now we have all of these different performance measures, and some people, they use many ways to statistically to try and expand their data set, and Nancy can really expound on that, and she has. But I just want to point out one thing, that the lesson we learned way back then, which is still the case now. Even after you've gotten your great ROC curve, your great area under the curve, and everything looks good, you go out in the field and you miss one obvious nodule, let's say a 15 millimeter nodule. The credibility with the physician is almost completely lost at that point. If they think that your algorithm, your AI algorithm, could just completely screw up. It's just like a car, an automated driving car that runs straight into a truck or a brick wall. It's the same issue. Is that they still have to stay on their toes. They have to look for really stupid mistakes that the AI algorithm can make. And then lastly, I just something that is particularly important with respect to Kiba. If you've got an AI algorithm and it's evaluated on a set of data that's very low resolution, and it attains one performance, and then you've got another algorithm and it's evaluated on a data set with very high resolution and other good image quality properties, that is a completely different starting situation. And accounting for the image quality is really important. Unfortunately, I don't have time to go into it here. This is supposed to be a very short presentation, but the KIBA CT small lung nodule profile provides mechanism for obtaining quantitative information about the performance, the image quality performance of a CT lung nodule scan, and that can be used to essentially estimate the difficulty of the dive, so to speak, and will help us better understand whether one algorithm or one algorithmic approach is better than another. But what I'd like to on this slide at least close with here is that we're still stuck with way too little data, and the fact that some of the major groups and organizations are still publishing with very old data sets. Even if they get large numbers, they're usually very old, 10, 20 years old data set, 15-year-old data set. So we're stuck really with insufficient data until we create a continuous, automated, quality controlled, and I would say global, but it doesn't have to be global, it could be national, data collection and creation system. And by the way, we recommended this at the last quantitative imaging workshop. Basically, we called it a global patient opt-in. And the idea is that if we automatically can collect from major electronic health records and PACS systems, when a patient, let's say, says they opt in, like you donate your organs to science, you can donate your data to science. And I mentioned earlier in this workshop, the GiveAScan. I still think there's a big opportunity to create if you will, a global nervous system where the data continuously streams, at least a small percentage of it, continuously streams into a global resource, or again, a national resource. And to make our lives easier, if we modify DICOM to better support de-identification, and there's quite a lot we can do, removing the need for manual evaluations and reviews of images for de-identification purposes, we can make this far more efficient. So I'm going to keep pushing to set up this continuous data collection and curation system. And there's multiple systems that are in development now that I'm involved with and others are involved with that will help with that. Lastly, I just want to discuss, next slide, one more thing. So I told you I've been at this for a long time, and I got a chance, I told you, to work at a neurobiology lab, and especially with confocal microscopy. Now, why are we looking at confocal microscopy? Because way back at the beginning, early stages of confocal microscopy and other microscopies, they realized they needed to do something. They needed to stabilize the image. And what you see here is a very expensive table that puts the whole system on a cushion of air. And if they don't do that, the vibration in the building and the vibration of the people working around and the computers and all of that will destroy that image in terms of it'll become a big blur instead of because of motion, because of the vibrations from the building. So what happened was over time, the entire neurobiology confocal microscopy field, essentially this became standard required. It became a standard required piece of equipment in order to study these really tiny nerve cells growing and interacting. And so what I'm trying to get at here is that we're now in KIBA, we're saying to the world, the lung cancer screening and lung nodule measurement world, that we need to control variability in a much more more careful way. We're not saying you should buy a table, a vibration dampening table. What we're saying is you need calibration phantoms and other tools like we've developed in Kiba. Don't have time to go into all of that, but some of the pushback we get from AI developers is, well, we want to be able to handle all that variability. Well, I would say to a point. I mean, you don't want to have to deal with major problems like for instance, the confocal microscopy world did. So I would say eventually calibration using phantoms and other methods and more automated methods will become standard, and the AI algorithms will be able to basically leverage that information and not have to try to detect something that is undetectable, for example, that's been motion blurred or other things. So next, and then just to drive this point home, if you've lost your resolution in your image because your scanner can't produce it or your scanner has some issue, which we see plenty of cases of, there's no algorithm, whether deep learning or others, that can restore it. Not a major loss of resolution. They can do small things on the side. So it's really important that we embrace these calibration methods and let the AI algorithms work with the best data. Garbage in is garbage out, and I agree with Mary Ellen on that. So that's my presentation. Thank you.
Thank you, Rick. And the next panelist is Tony Reeves, who's a professor in the School of Electrical and Computer Engineering at Cornell, has worked with the ILCAP group for a long time. Tony?
Thank you for reminding me to unmute myself. Okay. So I was tasked with a very simple issue, or a very single issue. What is the most difficult challenge to make AI work well? So I'm going to give an answer in the context of an academic engineer, which makes it a lot more easier. I think the previous speakers have really set the stage well. So I'm just going to try and focus in on, okay, how do we make this better for and have an improved performance? So technologies, we've got machine learning, deep learning as the standard, if you will, AI. And then we also have image measurement science, which is employing more formal methods to give very precise measurements in terms of, say, for lung cancer screening, nodule size or growth rate. And I'm going to address this sort of in the lung cancer screening setting. Nodules are the primary goal, but other goals include all other detectable diseases in the chest. So both AI and measurement science are evolving technologies when it comes to imaging. But they're also highly symbiotic technologies, so it makes no sense to sort of separate them from each other. As time goes on, they're going to integrate better, although the goals are slightly different between precise measurement, and for most of AI, it's more of a categorical assessment. And the requirement is for documented databases is the key to all these technologies. One thing where I call them evolving technologies, we know two things. Next year, they will be better than they are today. And 10 years from now, they'll be a lot better than they are today. Next slide, please. So what is the challenge? Is image quality, simply put. The first challenge is quantity, which is also a quality. If we look at the one successful application of AI to imaging, it's the diabetic retinopathy used from iFundus images. And they used a validation, I call it evaluation data set of about 10,000 cases, of which 1,000 were positives approximately, and a consistent protocol throughout the whole process. And results were excellent. This is in very sharp contrast to the types and the variety of data sets that we have, say, available in CT for lung cancer screening. Quality image data, by this I mean some kind of consistency with protocol. And we've been hearing about how we need to accept all kinds of different protocols in clinical practice. That's a barrier to the success of AI. Quality of a data documentation. When we're training these systems, we must have the best clinical evaluation in order for not to have the situation of garbage in, garbage out, which we've heard about, both for data quality and documentation quality. And finally, acquisition. And acquisition, we have such a range of different protocols that are adhered to in different ways. Is the scanner calibrated? Is the patient moving? All those kinds of issues. We should be able to do some kind of standardization there, and that will simply improve the quality of the outcome. So I just put this as quality, and these are what I think from an engineer are the quality issues. Many other quality issues may be relevant to a clinical setting, such as throughput, convenience to patient, and so on and so forth. Next slide, please. So here's my final slide, my wish list for how to resolve, make AI more successful. First thing is to convince CT manufacturers to provide a precision reconstruction. All systems clinically designed right now are designed to please the physician, whether they're using AI reconstructive algorithms, photoshopping, if I would like to call it that, to make the image pleasing, nice eye candy. I would like to challenge the manufacturers to come out with a scan that is numerically correct, that is geometrically correct, to the best that the scanner can do. This is no change in imaging dose to the patient. This is just how they would provide a second high resolution, undistorted scan for the purpose of computer analysis. And this should be as a companion to whatever scan is used for clinical evaluation by radiologists. And then second thing is to convince the physicians to actually acquire that scan so that now we have standardized protocol and we've optimized geometric precision and slice thickness and everything else that we need to do a quality assessment. Given that scan, then I think we would greatly improve the quality for measurement science and also for AI. Next, I would suggest what we really need to make AI successful is we need an evaluation data set, sometimes called validation. I think of it evaluation because you want to know if it's working. And that to me is a major effort that should have many stakeholders put into that and create a data set of 1,000+ nodules. If you're going to be looking at different sizes in pulmonary nodules, then you've got to balance that data set, else you're going to get highly biased outcomes. So a lot of care needs to go into that data set, what kind of protocols to accept it, and so on and so forth. And a minimum on that data size would probably be like 1,000 positive cases. And for that, how should that be applied? And I would also suggest that perhaps we provide a public data set of that form and also have a totally sequestered by FDA data set that is used for evaluating claims of submissions to FDA. That should be a living data set that evolves as technology evolves and as we learn more and gain more about the data sets and as we change the CT protocols. And finally, if we want the AI to improve, we have to provide or make available documented training data sets. And that would be much better done if it was done in a collaborative rather than competitive environment. Every manufacturer will have access to their own training data, but one can certainly, hopefully, create a global baseline that will achieve most of the performance goals that are needed. So with that, we'll conclude this presentation. Thank you.
Thank you, Tony. And the next panelist is Timur Kadir, who is the Chief Science and Technology Officer for Uptellum, which is a company developing AI for lung cancer CT screening. And presumably their products will meet all of the wish lists that we've just been hearing about today for both clinical and technical users. So, Dr. Kadir.
Thank you very much. Yes, absolutely. And it's available in all good stores. You can order it today as soon as you leave this presentation. So thank you for the introduction. My name's Timur. I'm based out of the UK in Oxford. I have a sort of dual role. I'm the CTO of Uptellum. I also do research at the University of Oxford with the machine learning lab here in different areas, including spinal MRI, which is a different topic for a different day. But what I wanted to cover today in the 5 or 6 minutes I have is to tell you a little bit about the journey we took to get to here. So this whole project started actually when I was the CTO of another company, and a company called Murata that makes imaging software for PET and nuclear medicine and radiation oncology. And we spun this business out of that business to focus more on the diagnostic side rather than just the reading side. Next slide, please. And so before I sort of go into the main bit of what I wanted to cover and what I was asked to talk about, which was really the challenges of how we bring a product to market, I thought it would be sensible to mention to you at least what are some of our product, what does our product actually do, and what are the different elements of it, and then I'll dive into each of these. So this isn't intended to be an advertisement, although I have used one of our slides that we give to customers who are interested. So the product is called the Virtual Nodule Clinic, and it's designed for actually not just for screening, which is coming a little later. It's also designed for incidentally detected nodules. So I'm going to cover both here because they are related. It helps identify the patients that need to be tracked either in the screening setting because they've been enrolled or in incidentally detected nodules. It helps on the tracking side. It of course gives you access to the information needed, the images, the reports from the radiologist and so on and so forth. And the AI piece really is only one out of these 4 things. And that's kind of, I think, ties into some of the points that have been made earlier on. It isn't so much about algorithms from a company's perspective or even from a user's, from a clinician's perspective. You have to provide a complete product. And this is at least one of our products that tries to do this in the context of lung cancer. So in the last piece, which is really the AI piece, what we do there is provide a score that is there to assist the physician, and we target this at radiologists and pulmonologists in managing these patients, whoever's involved either in an incidental or in screening. So that's what we do, and that's what the product does. Now I thought in the next slide I will take you through the interesting journey and challenges we had. And I picked 3 areas that I highlighted. Actually, during the talks I was watching earlier on, actually some very good points were made, so I added a few more along the way. So I might add a few more to these. But as I said, we work on screening and incidentally detected nodules. Now, when we first approached this, we took a rather naive approach. This is maybe 5 years ago. It's just a nodule, right? I mean, who cares whether it's been detected in screening or incidental? You still have to detect it, you still have to stratify it, you still have to produce a score, you still have to show that it helps. Actually, the 2 use cases and supporting these 2 use cases presents a very interesting challenge from a product point of view. And getting to the question that the AI is attempting to address, it was actually quite challenging. And I'll give you an example of this. In the UK, the way the system works here, rule out is very interesting. And I don't mean rule out as in rule out from some procedure or rule out from further from an investigative procedure and just follow with imaging. What's interesting here is that decision that physicians make when they choose to follow an incidental nodule at all. So we call this hard rule out because people who are being ruled out from that are actually being sent home. Interestingly, in the US, when we came to first investigate this product, that's not even a use case, because it's just the sort of economics of it all and the sort of legal side of it sort of really doesn't make that interesting. And so that was an interesting challenge, because what it meant was we had to realign our use cases and our products for the US market. So what I'm trying to tell you is that the national guidelines and the processes that are followed, whether in incidental or screening, really dictate how some of these things, how some of the algorithms are placed. So what this actually means is, on the UK trial that we have running right now, which is the IDEAL trial, that's looking at hard rule out. That's sending people home. So our sensitivity has to be super high. And so, because you don't want to send anyone home with cancer. Whereas in the US, we repositioned it under the ACCP guidelines, which is really about looking to see if you follow somebody with imaging, let's say below 5% risk, below 10% risk, something like that, or whether you do an invasive procedure in the intermediate risk, somewhere in the, let's say, 30–40%, or if it's above 60–70%, then you might actually send them straight to surgery or something, or a pathway there. That's assumed to be a cancer. So very different use case. So that's one challenge that took a little while to figure out for us. Now, data has been mentioned quite a lot. I should probably point out what we mean by data and what we mean by ground truth. So for us, data has to be not just someone's opinion of what you think this nodule is, it has to actually be the ground truth. So for us, what we define that to mean from the very beginning, it's a biopsy proven cancer. If it's benign, then that's been followed for at least 2 years. And so it makes an interesting challenge for where you collect data that's been treated with radiation therapy, for example. We can't include that because unless there was a biopsy performed on that case, if it was just treated with radiation for whatever reason, then we can't use that in our data set. And so again, incidental use cases present another challenge. There's a very wide range of protocols that are used to follow incidental nodules. Here, screening presented an actual opportunity for us because it's a controlled protocol. There's been that's been discussed in this meeting. A lot of work has been done into the protocols needs to be used. And although the images are lower dose and maybe that presents another challenge, at least the variety that we have to deal with is a lot less. So just to give you an idea, to handle the incidental nodules, and this even went into our discussions with the FDA, we had 40 different protocols that we were handling, up to 2.5 millimeter, from about 0.5 millimeter thickness up to 2.5 millimeter thickness, and different scanners, all the major manufacturers. And so that presents a real challenge on the incidental side. On the screening side, it's much more controlled, so we took advantage of that. The last thing I've got on my slide, although I've got many more points I could make, is really the point that was made earlier on, that what's needed is a product, not an algorithm. And this is not just for the user. This is also for us, because in the end, to make the company work, we have to sell a product that someone will actually buy. And so for that, we need workflow, we need integration, we need a validated algorithm and a validated product, and it has to go through the FDA and it has to be cleared and all the rest of it. And that isn't, it might not seem the most exciting part of the process from an algorithmic computer science point of view, but of course, it is what's necessary, and that's why you have people experienced in bringing medical products into the market. So just to give you a flavor for some of that stuff, in terms of our the steps we've gone through, we took quite a long time to work out what the product should do. We market tested that, we built prototypes, we tested those. When it came to the integration, it of course has to integrate with the EMR, with the PACS, with the workflow, and that took quite a long time as well. Every installation that we do has its own challenges. As you all know, DICOM is DICOM, but of course DICOM is, many, many different flavors amongst the manufacturers. When it comes to the validation side of things, what we chose to do, we put out a couple of papers working on with the UK side. We put that out with, in thorax and BMJ thorax, looking at retrospective validation. And we're in the Blue Journal, this is the pulmonary journal in the US. We worked with our colleagues at Vanderbilt and Pierre Massion, validating the algorithm on their data as well as the UK data. So those are 2 papers. We've made them publicly available. But following that, for the build up to the 510K submission that we made several pilot studies on the impact of the tool on the readers themselves. And this included radiologists as well as pulmonologists, because what we learned is that in many cases, for at least for incidental nodules, not so much for screening, but for incidental nodules, the pulmonologists are having to read in addition to what the radiologist did, which is an interesting lesson there. And so that's why our reader study was designed to handle that. Again, that was a lesson learned, that in real life, we thought that it would just be a radiology tool, but actually what it turns out is that you have to be able to address the bigger picture. And so those are some of the key lessons we learned on the validation side. We're in the process of the whole regulatory side. So that flow chart that was shown at the beginning of this session, yeah, we've traveled quite a lot of that. We're not all the way through yet. But I think some of the key lessons that we learned that I try to highlight here, I think really it was Ella that sort of picked this up much earlier on, that was really there are financial issues associated with this. In the end, for a company, in order for it to make sense for us to get investors and to actually invest in these products, we have to be able to make a product that someone buys. And for that, it presents its own interesting challenges. It isn't enough just to make the algorithm. We have to address the whole use case, but also make it compelling for the user to actually use in their day-to-day workflow, rather than be some specialized little algorithm that only gets used on some weird use case. We have to address the mass use case. And in our case, in the case of incidentals, that meant we had to deal with a very wide range of protocols. On the screening side, it meant we had to address the questions where AI could actually impact the decisions being made. And that's not the same thing. LungRads 1 and 2, you may not have anything to say about those. You may only have something to say about LungRads 3 and 4. It's different. The specifics around the use cases have a major impact into the way these products need to be designed. And I think with that, I think I'll draw my talk to a close. Thank you very much.
Thank you, Timur. And so any of you who are looking at the clock know that we have run past the scheduled time, but because this was a break, advantage of a virtual meeting is that people can take a break, sort of ad lib. So we're going to continue on with our last panelist here, and either have a very short break or maybe no break at the end. But our next panelist is Dr. Robert Ochs from the FDA, Deputy Office Director, the Radiological Health in the Office of In Vitro Diagnostics, which sounds like it's not imaging, but it's also the Office for Radiological Health, and is the office that does have oversight over imaging products, such as the AI products that we're talking about. So, Dr. Ochs.
Thank you. So I've been asked to speak a little bit about what are some of the challenges that CHRH is grappling with to ensure safe and effective imaging AI products. So our mission is focused on ensuring that safe and effective medical devices are available to patients and healthcare providers, and AI has a significant potential to benefit patients by expanding access to imaging and enabling higher quality care. Many of the challenges that we foresee are due to the increasing number of complex AI submissions with variations in the intended users, such as users without specialized training, use at different stages of the clinical workflow, such as guiding image acquisition. And there's also increasing complexity and challenges from AI that incorporates new information, such as information from the patient's medical record into the algorithm, and new technology, such as adaptive and continuously learning AI. The increasing complexity presents challenges given the likely need for additional data or changes to the evaluation method for each difference. So I agree with the panelists who have mentioned the importance of well-characterized data sets with sound test strategies to address challenges in the development of AI products. Common data sets and benchmarks for performance would help enable a standardized and streamlined framework for evaluating these new systems. In addition, standards and new methodology would also support the development and use of safe and effective AI systems, including best practices for algorithm development, deployment, updates, and providing transparency to users, and also methodology for real-world performance monitoring and device evaluation. which will support understanding and evaluating the safety and effectiveness of these devices once deployed. But also, these methods and policies for real-world performance monitoring may support expansion of the AI products to new indications or support performance updates, while also reducing the cost of collecting and curating new data sets. So at FDA, we are working on policies and guidance to support the development of AI across many disciplines, including policies specific to AI products and policies specific to clinical decision support systems, which may integrate medical information from the medical record to support patient management. My advice for developers of these products include early engagement with FDA through the pre-submission process, with a clearly defined intended use of the device, and ensuring that the data set, statistics, and study design are consistent and will support its generalizability. And also understanding how the device will fit into the clinical workflow with strategies to address the bias, risks, and limitations of the device. So work on well-characterized data sets, standards, methodology, and early engagement with FDA will all support the introduction of safe and effective AI technologies into clinical practice and address some of these challenges. Thank you.
Thank you, Robert. So lots of good information, lots of challenges in today's session. And I was thinking back to Ella Kazaruni's comment earlier that maybe our biggest challenge is to prioritize the challenges and decide which ones to work on. There's so many that it would be daunting to try to deal with them all. So we need to decide which ones. So thank you to all of our panelists for both hours and to the organizers for helping to set this up. And shall we take a 5-minute break? And then we'll start again about 3:30, right? Eastern time. Thank you.